Hello, and welcome to today's training, What Mental Health Providers Need to Know About Primary Care Behavioral Health Integration with Risa Weisberg, PhD. I am Mary Geis, Program Director at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Risa Weisberg, PhD. I could go on and on about Dr. Weisberg and her professional accomplishments. Not only is she an expert on primary care and behavioral health integration, she is also a respected leader within ADAA. A member since 2002, Dr. Weisberg has received the prestigious ADAA Member of Distinction Award and contributed to several ADAA committees, most recently being elected to serve as treasurer of our board of directors. I will now stop talking and turn the screen over to our presenter. There might be a brief pause while I do that, and Dr. Weisberg, you can take it away.
Thank you so much, Mary. I appreciate it. I just want to preface this by saying that you can't see me, just my screen, and I do have a little bit of a cold. So if you hear me pause for a little bit, it's not that you lost your connection, it's just that I stopped to take a drink of water so that I could continue on. So no worries there. Okay, so before we get started, just my disclosure information, I'll be presenting a little bit of data today that comes from some research that was supported by Pfizer Inc., but I don't currently have any support from Pfizer or any other industry sponsor, and I am currently an employee of the federal government. Throughout this presentation, ADA is going to be embedding 4 different letters. They'll be presented both visually, and then I will also say them aloud at intervals throughout the webinar. In order for you to receive CE credit, you need to be able to list all 4 letters in your webinar evaluation. So please pay attention to the letters, and you likely want to jot them down. The first letter is the letter A. So what is primary care behavioral health? Well, you've probably heard a number of different terms that all sound somewhat similar being thrown around. These may be integrated care, primary care integration, patient-centered care, coordinated care, and it can be a little confusing to navigate the literature in this area as well, or to know how to speak about it. This is a really helpful graphic set up by C.J. Peek and his colleagues. And for those of you who are really interested in this area, I recommend that you look up this article. You have the citation in your materials, but most of us tend to just refer to this as the lexicon. And what's important to know at this point is just that almost all of these terms really center around the main concept of providing patient-centered care. So providing care to individuals that is really centered around them as a whole person and what their whole health needs are, as opposed to just the way that each individual healthcare system operates. And within that, there are a number of different ways to approach patient-centered care, but when we talk about integrated primary care or primary care behavioral health, which is the term that I'll be using most today, what we're really talking about is providing whole health care in a primary care setting that encompasses treatment of mental health problems, treatment of what might be typically thought of in the past as behavioral medicine problems or health psychology problems, and substance abuse care. So it's really all of the roles of a mental health clinician beyond just that of treating psychiatric problems jointly in this way of providing whole health care for the patient. So my goals today are really twofold. It's to give you a regardless of whether or not you're interested in becoming a primary care behavioral health provider, or you are interested in maintaining your own individual specialty mental health practice with a better understanding of what primary care behavioral health is and how you might interface with it. My overarching goal is really just to give you some background about the terminology and what this work really looks like and what you need to know at the very basic level for how to get started. So most systems are hoping to move towards what we call integrated care. And this really works in a linear trajectory, starting over on the far left side with traditional care. In traditional care, which is how most of us have been trained, the specialty mental health team provides care for mental health or behavioral medicine problems in very different settings, in a very different healthcare system than the primary care team. And there's often little or sometimes really no communication between those systems or teams at all. In coordinated care, the care is still provided at a distance in separate settings and separate systems, but there's more of a seamless communication that goes on between the providers. And for those of you who want to maintain your specialty mental health setting treatments, this might be an area for you to aim for, is moving from traditional care to coordinated care. In co-located care, the behavioral health team and the medical services are provided in the same location, often sharing the same space, but they're provided very separately. Typically, billing is separate, and the team may really not share much of the same staff. They may or may not, and they may be sort of put there by separate healthcare systems, but they share a space. In integrated care, there's one team. The behavioral health provider is part of the primary care staff and team. They're sharing one support staff, they're sharing one electronic medical record, and they're providing care in a very holistic, integrated way with one treatment plan. This is our next letter for your webinar evaluation. The letter is O. Make sure you jot that down. So why should behavioral health providers collaborate with primary care? Well, we know that the majority of individuals who seek mental health services turn either to primary care first or as their only source of treatment, and that more than half of common mental health problems are treated exclusively in primary care. This means that primary care professionals do a lot of the work of providing mental health treatment. They prescribe about 60 to 70% of the psychotropic medications in the U.S., and it's how primary care providers spend a great deal of their time. They spend about 25% of their work week providing direct treatment for psychiatric problems. Despite that, many primary care patients who have mental health problems go untreated. This is some of our own data on anxiety disorders in primary care, and we found that about almost half of primary care patients who had a current anxiety disorder were not receiving any type of mental health treatment. We also know that collaboration with primary care provides us with the opportunity to assist both patients and the primary care providers in the treatment of medical conditions. We know there's a great deal of evidence that shows that behavioral health techniques can be helpful in treatment of a large range of non-psychiatric medical problems. Further, behavior modification is really a key factor in nearly all disorders and problems that primary care providers deal with, whether that's problems that are related to lifestyle factors such as smoking, poor nutrition, sedentary lifestyle, risk-taking behavior, or really just difficulty adhering to treatment regimens, to difficulty taking their medications regularly, difficulty making lifestyle changes for diabetic care, or alcohol and substance use. So there's a great number of ways in which we may help primary care providers and patients get better treatment. We also know that primary care patients tend not to follow through on referrals to specialty mental health care. About 1/3 to 1/2 of patients never attend even their first specialty mental health visit. And a number of the reasons that they cite for failing to follow through are reasons that might be addressed if we were better coordinated and collaborating, or maybe even co-located in primary care, such as the stigma of reaching out to somebody who is a specialty mental health provider, lack of readiness for change, or just really finding their offices to be inaccessible. So how does all that affect you directly in your practice? Well, the Affordable Care Act included a financial impetus for both providers and hospitals and systems to become part of accountable care organizations. And ACOs are really just groups of medical providers that accept payments based on quality rather than on a more fee-for-service type of plan. And so with the ACA and the Mental Health Parity Act, there was a mandate that in order to become an accountable care organization, systems needed to provide behavioral health services as part of the services of their ACO. Now, the ACOs had an option. They could either integrate behavioral health providers directly into their accountable care organization, or they could utilize referrals to standalone specialty mental health, specialty behavioral health services. So all of this means that lots and lots of hospital systems sought to embed better behavioral health services and to become more integrated, or to build better relationships with mental health providers in the community in order to get this ACO status, which there was a strong financial impetus to do. We know that the Accountable Care Act is likely going to be repealed, and it's unknown what the replacement will look like, but I think it's very doubtful that integration will be undone, as it's just proven too useful to too many hospital sites. So whether you're interested in working directly in primary care, and this is really a growth area, and many sites are looking to hire behavioral health providers in their systems and in their primary care settings, or you want to stay in specialty mental health but grow your practice or maintain your practice, building those good relationships with primary care providers and even with the embedded behavioral health providers who are in those systems may be very important for you in the continuity of your work. We know that primary care providers are very reluctant to refer to mental health providers that they haven't had personal contact with and don't feel a personal connection to. It's very hard for them to navigate who's better trained. They don't really know our system as well. And so they tend to really rely on folks in the community that they know, that they've had patients who've had good experiences with, or that they've met or known personally in order to make those referrals. So how does primary care behavioral health differ from traditional mental health? Well, in order to do this work, whether at a distance, again, through collaboration, or embedding yourself in the primary care setting, you need to really understand the primary care setting and the culture. This is a culture in which things move very, very quickly. Time and space equal money. So it's very common in primary care offices that primary care docs don't actually have their own individual office. A patient gets roomed, the primary care docs go to see that patient in the room, and then they may jump to a patient in another room while a nursing team comes into the original room, and the docs kind of move between rooms. That's very often the system as well that you may have if you're working in that setting. You may not get your own office. You may be asked to move around between exam rooms. Interruptions are very frequent and expected. Most of us have had this experience as a primary care patient when a nurse or a medical assistant has knocked on the door and come in during the session. And that's part of the culture. So you can expect that even as a behavioral health provider, you may get interrupted because there's a patient in the next room who's having a more urgent behavioral health problem, and they need your assistance with it. We also know there that mental health diagnoses are far less specific than they would be in specialty mental health. They're often anxiety, unspecified, or depressive state. And importantly, it's a culture in which the providers are very used to sharing notes. So they share notes with one another. They share notes often with other providers that they refer to. It's very common. It's actually sort of unheard of to refer a patient, let's say, to a cardiologist and have the cardiologist not send back a full report and all their notes to the primary care doctor. And again, this is something most of us know. When we go to a specialist, right away on their intake forms, they ask us who our primary care doc is, and they want to fax our records back to them. It's also important to understand a little bit of what it's like to be a primary care provider. This is a really tough job. Due to increasing economic pressure, these folks have very, very short visits. The average visit is less than 13 minutes for a primary care provider. And in that time, these providers need to deal with a great number of competing demands. They need to assess and address the patient's chief complaint or primary reason for that visit. They need to check in on all other active conditions on the patient's problem list, make sure they haven't missed an exacerbation of something. They need to see if the patient needs any medication refills. There may be a set of health promotion guidelines that their particular hospital is mandating that they address. And there also is likely a number of specialties asking them or mandating that they do specific screenings. So screening for diabetes, screening for hypertension. Here in the VA, we are mandated in primary care to screen for depression. So sometimes these are mental health, sometimes they're not. A lot to cover in 13 minutes. When they're trying to cover these things, they tend to address the things that they think are the most likely to be a major health problem for the patient before the next time they see them. This quotation, I think, sums it up nicely, that doctors tend to get sued for missing biomedical diagnoses, not psychosocial ones. So in 13 minutes, the psychosocial complaints often get pushed to the end, or unless they're the main presenting complaint, sometimes don't get addressed at all. It's also important to understand that primary care providers are not reimbursed, frankly, neither are we, for the time that they spend in collaboration with other health providers. But if our average visit is 45 to 60 minutes, spending 10 minutes collaborating doesn't really feel like a huge financial cost. If their average visit is 13 minutes, spending 10 to 15 minutes talking to you about a shared patient is time that they could have billed for a full visit. So the financial pressure makes it difficult sometimes for them to communicate and collaborate with us in the way that we might communicate and collaborate with one another. And that's very important to realize. It's also important to understand how the primary care patient may differ from the patients that you see in specialty mental health. They tend to be, not surprisingly, more likely to have medical problems. They're older, often less educated, poorer, and more likely to be a member of an ethnic minority group than are the individuals who find their way into specialty mental health care. They're also less likely to have accepted a mental health definition or conceptualization of their symptoms, and therefore may be less ready to make behavioral changes. They also are less likely to be coming to you with a very specific mental health diagnosis. And lastly, though in primary care as a whole, we don't necessarily see more access to problems, amongst the patients who are referred to a behavioral health provider, there's an increased rate of access to comorbidity, in part because primary care docs are most likely to refer the patients that they have difficulty working with, and sometimes this is due to access to comorbidity. So what does that mean for your role? How does the role of a primary care behavioral health provider differ from that of a specialty mental health provider? Well, we know in specialty mental health, our average sessions are about 45 to 60 minutes. We tend to do very regularly scheduled appointments with folks. Maybe Mr. Jones comes in every Monday at 7 p.m. We make full diagnostic assessments. When someone first comes in, we want to run through all of our DSM or ICD criteria and make a full diagnosis. And then our treatment is typically focused on those diagnoses, really with the goal of full recovery of the symptoms and full recovery from that diagnostic criteria. We keep our chart notes private and confidential, and we write our notes often for our own purposes, to jar our memory and to keep all the information that we want to have when we are treating this patient. We also are very likely to have a very specialized orientation. So those of us in ADAA may specialize in anxiety, or we may specialize in depression, or we may specialize not in anxiety, but in social phobia, or we may specialize in OCD, or we may even be more specialized than that. We may only specialize in hoarding. We may only specialize in public speaking. Our field has moved more and more to this very, very specialized type of orientation. And we see ourselves as the primary provider and the main doctor for our patients. They come to see us, and we are their healthcare provider when they're in the room with us. And most of the work that we do with our patients and that we do directly related to our patients' well-being is completed during patient sessions. We typically give patients homework to do outside of settings, but we interface with the patient's health mostly during our sessions with the patient. In behavioral health provision, things look a lot of very differently. Our typical sessions are only 15 to 30 minutes. We're trying to really reach the whole population of patients at the primary care site who may benefit from our help. And as you saw, because we're addressing mental health problems, substance abuse problems, and a whole gamut of lifestyle modification and behavioral medicine problems and just physical health problems, it tends to be really almost every patient could benefit from us. And so we can't be seeing folks for as long. So 15 to 30 minute sessions. Those sessions tend not to be very regularly scheduled. We may see someone only once every couple of weeks at first, maybe move to once a month. Maybe we'll have open access and say, you know, I'm here every Monday afternoons and Thursday mornings in an open clinic. And if you need me at any time, just stop by any Monday afternoon. And you may have to wait a little bit. It might be with someone else. But stop by, put your name on the wait list, and I'll see you on Monday. You can come whenever you need me. Or we may provide very episodic care. After a short little burst of treatment, we may say, I think you're doing pretty well. You can take some of this stuff on your own. Come back anytime you need to in the future. Since you have this long-term relationship with your primary care doc, you know, maybe when you check in with him again in 6 months, come stop by and see me. Our assessments are much briefer and are much more focused on functionality. What types of symptoms and problems are interfering in this patient's ability to function right now? And our treatment, therefore, is very focused on improving functioning. What kind of discrete lifestyle changes or practices can we help this person learn that will improve their functioning? Sometimes our treatment is really focused on getting this patient sort of started and off the ground with an understanding that they are then likely going to need more specialty mental health care than we can provide in our short-term treatments, and helping them to feel comfortable with folks like us and facilitating a good referral to the community for longer-term treatment. We share our notes in the regular medical chart, typically these days in an electronic medical record, and they're shared with the primary care provider. I'll talk more about notes in a little bit, but I also think it's helpful often to share those notes not just with the primary care provider, but also with the patient, which is something that's less common in specialty mental health care. We need to have a very, very generalist orientation. So primary care providers see our specialty as behavioral health. That's a specialty in and of itself. So we're not specializing in hoarding. We're not specializing in anxiety. We're the behavioral health specialist. And we really need to be able to see all comers, all patients who may need some type of behavioral health treatment. We're also really not their primary provider. their primary care provider is. They're the main doc. They're the main nurse practitioner. Our job is to help that primary care provider better help treat their patient. And we're very ancillary to that relationship. And in part because of that, a lot of the work that we do may occur without the patient even being present. It may occur via consultation with the primary care provider. Primary care providers seeking us out to say, I have this patient, this is what's going on with them, what do you think might be helpful? Or this person seems like they really have a very, very severe mental health problem and I think they need a referral to the community. Can you just help me to do that for them? So sometimes you're doing work that's helping the primary care provider and the patient without ever actually even meeting with the patient. Okay, hope you're paying attention. Here is the third letter that you need to jot down. This is the letter F. So given what you now kind of know about the setting and primary care providers, how do you best communicate with primary care providers? Well, what I really hope you'll take from this more than anything is this idea that you really, again, whether or not you're going to be working directly in primary care or staying in your specialty mental health treatment settings, I encourage you to increase your communication with primary care providers. They want to hear from us. It is a very, very common complaint for them to say, I never hear anything from my patient's therapist. Even if I'm the one who referred my patient to the therapist, I never hear back. Again, this is hugely different from the way other medical and health providers interface with primary care. They send their notes and their records back. They send a summary back. They may get on the phone and chat with the provider. Primary care providers feel like sending into mental health is sending their patients to a black box, and they never hear back. It's extremely frustrating for them and makes it very difficult for them to provide whole person, patient-centered care for their patients. So reach out and communicate. Send a thank you note for your referrals. Again, if part of the goal of doing this should be to improve your patient's well-being and care, but part of it may be to build your practice. Send those thank you notes when you get a referral. Even when I'm embedded in the primary care site, I still thank the docs for sending me a referral. Sometimes I'll do that just as part of the electronic medical record. You know, I can send a brief note in the record that says, thank you so much for sending me Mr. Jones. I want to let you know that I'm going to see him next Tuesday. Or in the community, sending that letter. FaceTime really, really counts. Again, whether you're embedded or in a separate setting. I've too often seen embedded or co-located behavioral health providers really fail to work well in an integrated type of primary care behavioral health model because they come into the space, they have an office, they close their door, they see patients with their door closed in a row. At the end of the day, they leave. And the primary care providers don't really interface with them. FaceTime counts. You need to be present. And this is even more important, I think, to think about if you're in the community and not embedded directly in primary care. Get to know the primary care providers in your community. They're not going to refer to people that they don't know. And if they actually get to lay eyes on you, that helps a ton. Try to stop by, maybe contact a primary care site and find out when they have team meetings and if you would be invited to come by and introduce yourself. Bring food if possible. They work long hours in busy, busy shifts. Snacks are always hugely appreciated. Really get to know the team. And don't forget, in getting to know the team, the other medical and support staff. Don't just focus on the docs. Very often, it's the nurses or the medical assistants that might be the ones to kind of help make the referrals to. And if you're trying to work more seamlessly embedded as a primary care behavioral health provider in the primary care site, getting to know that team, getting to know the reception team, and really sharing resources with them is going to be essential for the good integrated flow of your work. How do you start this conversation with primary care providers? Keeping in mind that this weird sort of mixed bag, that they really want to hear from you, they're frustrated that they don't, and yet they don't have much time to talk to you, and they're not reimbursed for any of the time they're talking to you. So it's really helpful to go into things with a set of questions in mind that you most want to know. I think this is an excellent list that comes from an article that I think you have the full citation for in these materials from Gunn and Blount. So starting with, if it's a new referral or a new patient that you're seeing, what's the primary care provider's primary concern for this patient? What are they most worried about for this patient? And relatedly, what would they think a successful outcome for this patient would be? How would they know that their patient got better from seeing you? How well does the primary care provider know this patient and his or her social situation? Very often, these primary care providers have a very, very long-term relationship with their patients. If you're working with family medicine providers, they may be treating the entire family for many, many generations. And so they may not just know this patient, but they may know this patient's parents, siblings, spouse, children, and really be able to provide extremely valuable information about the social context of their problems. Get that information from them. It can save you a great deal of time. Does the primary care provider have any advice for you about how to develop a working relationship with the patient? Again, this is likely a patient that the provider has been working with for a long time. What can they tell you about what works well with this patient in particular and what doesn't? Find out about their medical problems. Are there any medical problems that the patient has that might be relevant to their current psychological state? And similarly, I'd add any medical problems that the patient has that the doc really wants your help with. So, you know, this patient has really poorly controlled diabetes. I know he's also depressed, and that may be an important thing for you to focus on with him, but if he doesn't get his A1C under control, he's not going to be around long. He really, really needs some help with this. Relatedly, how well does this patient follow the doc's medical advice? And is this something that the doc wants you to help with? Does the doc think that the patient requires any psychotropic medication? Is the patient on any current psychotropic medication? Or has the provider been trying to get them on something and the patient has been refusing? And very importantly, ask the provider how they would like to proceed with communication and collaboration about this patient going forward. All sites, all providers tend to have their own unique ways that they want to do this. And so it's I'd really caution against setting up a system for your practice where you say, okay, I'm going to regularly, send all notes in this manner, in this way for all patients. Talk to each provider, find out how they want to get the information. Some settings have very secure encrypted emails, and if you're working within that system, you may be able to actually send some information that way or secure fax lines. In other systems, you really can't send personal health information. That way it's all going to have to be via phone. You need to sort of figure those details out in terms of what you're able to do and what you're able to share. But also, how much information does the provider want? Some providers want to be updated every time you see the patient. More often, providers really only want you to reach out to them if there is a very specific problem going on with the patient, or if there's something that's changed, a real change in the patient's status that you think the provider needs to know about. Some providers really mostly want to know treatment summary. From this point on, they're like, okay, you're on your own until the end of your course of treatment, and then please send me a summary. Others really want regular progress notes. So find out what works best for the provider and try to work within that system. They'll really appreciate it. A couple of ways in which I've seen people get into trouble with communication. Some of these may be obvious based on what we just talked about, but I want to make sure to point them out. So again, failing to find out what the preferred means of communication is, and sort of bombarding the providers with more information than they want, or doing things that seem like they would work well, but then there's a system breakdown. So for example, at one of the sites I worked at, there was a very secured fax system where if we faxed our notes, they went directly into the patient's electronic medical record. And so when we first met with office staff, they recommended to us that that was the best way to get the information to the providers, was to fax these things directly into the medical record. And that was easy and seamless for us, and it all worked really well. Well, it turns out that when those fax documents go into the medical record, they don't actually go into the main part of the record that the docs ever view. They go into this sort of tab that just says additional documentation, and the docs were never looking there. So the providers we were working with started to complain to us that they never heard back from us and never knew anything about our patients, while we thought we were sending them regular updates. So again, make sure you really have the communication on both ends of how they want to get this information and how they're going to receive it when it gets to the other side. Be careful of taking up too much of the primary care provider's time. I love personal communication, specifically when it's very important types of things, like those initial first time you see a patient. I think a phone call works better than just a report, if possible, to ask those kinds of questions that we just went over. But trying to make things very focused and very brief. When I often collaborate with other behavioral health or mental health providers, we'll sometimes chat with one another, onwards of 20 minutes about our patient. Really, you want to try and get your information in 5-10 minutes, if possible, with a primary care provider. The other thing I've seen happen all too often, and it's really sort of embarrassing, I think, for us as mental health specialists, is really forgetting to be respectful and honor the fact that the primary care provider really is very expert. They're expert on a very great many number of things, and particularly maybe very expert about this patient. They may have known this patient, as I mentioned, for a very long time. They know their entire family. So really taking a stance in your communication with them about not just providing them with information or telling them what to do or telling them what you know, but this open-minded, how can they help you better help their patient as well? What do they know about this patient that you need to understand? What is their perspective on the patient? And then when there's things that you think, maybe the doc doesn't understand this very specialized part of mental health information or behavioral health information, providing it to them in a way that is very respectful of their general knowledge. I've heard too often providers kind of talk about, oh, docs don't know anything about how to treat mental health problems, or they don't even care about mental health problems and never ask these things. Just be careful that you're kind of not going into it with that type of an attitude. It really comes across, and as you can imagine, is very distasteful to the docs. And then the flip side of that, though, is I've seen behavioral health providers go too far in the opposite direction and really feel uncomfortable offering the primary care provider direct advice. I think we are often in a role where we think of ourselves, again, very specialized in one particular field or one particular part of the field, and in part through our very scientifically based training, we we couch things in a lot of, well, the data say that this and this might work, but we don't really know. Docs really want us to give them very direct advice, these patients. So that's what's going to feel the most helpful for them in the brief amount of time. So being comfortable in a respectful way to also say, you know, I was meeting with Dr. Jones, with Mr. Jones, you're absolutely right. He really is very depressed right now, and his diabetic management is really poor. And, you know, I think those things are interfacing with each other really very badly. Part of why he's not controlling his diabetes well is that in his depression, he is overeating terribly, and he's eating lots and lots of junk food, and that's getting in the way. And he just has no motivation at all to change any of this. And he and I have been talking. I mean, his sleep's also terrible, and his depression seems like it's getting worse and worse. And he and I have been talking, and he's never tried any type of medication for his depression, and he's really interested in it. And I think that might not necessarily be a bad idea in this case. You know, have you considered prescribing him something for his depression? And so taking the stance where even if you're not a prescriber yourself, of being comfortable kind of recommending to the doc that they might want to prescribe a medication. And the doc may come back and ask you, well, what would you recommend you prescribe to them? That's often a question that non-prescribers get very uncomfortable with. Being comfortable, find that comfort level where you're not saying, well, this person should have this exact medication, but where you can at that point say, well, the data suggests for the types of problems he has that, you know, an SSRI or an SNRI might be the most helpful. Here's some more, I can send you some more information or a literature review of common SNRIs if that would be helpful for you, or something like that. All right, here's our last of the 4 letters. It's a letter S. Please make sure you record that. The last letter is S. I feel a little like Vanna White with the letters, but there you go. So how do you write your notes? First of all, you want to make sure that your patient understands that the notes that you are writing are going to be shared with their primary care provider. Whether you do this as part of I recommend actually doing this as part of your consent for treatment with all patients and really pointing out and making it clear. Or if you're not physically in the primary care site, you probably will also need to get a release of information directly to provide that information to the primary care provider. If you're if you're serving as a primary care behavioral health provider in primary care, and you're part of the same system, you really don't technically need that release of information, but I would still say that you should make sure it's in your consent form, that they know that you're providing everything in the shared record. It is very, very rare in my personal experience that a patient doesn't want this information shared. Often they are surprised that you even need a release or that you weren't going to share it. They just, especially if you're located in the setting, they assume that you're communicating about their health. They want you to be communicating about their health. They understand that that's in the best interest of their good treatment. I recommend that you use your notes in the medical record to communicate and educate the primary care team about your treatment plan. I'll talk more about that in a minute. But you want to use language that helps them understand what it is that you're doing. You want to be very, very brief. Docs don't have a lot of time to read these notes. They often don't read them at all, but they're more likely to read them if they're brief. You do need to consider whatever your billing regulations are, though. There may be certain things in your health system that you have to include in all your notes. I know some systems have to include like a brief mental status report, things like that. If you have to, then do so. But if you do have to, try to clump all those things into like the very top of the note. Don't boldface them, and put the things that the docs really need to look at and that you want to get their attention about sort of more bold-faced in a different part of the note. You want to avoid using jargon whenever possible, and if you do need to use it, make sure you define your terms. And you want to remember that these notes are going to be part of their general medical record. So in part in the service of brevity, but also in part in maintaining the patient's privacy, you really don't want to provide a lot of details. The exact nature of this patient's trauma history, for example, really doesn't belong in these kind of notes. You can simply say that you are addressing this patient's history of childhood trauma, and that's all that needs to be in the note when it comes to that sort of specific piece about the trauma. I'd also recommend that you consider sharing your note with the patient as well as the provider. A lot of your goal is to help the patient and the provider better work together in a long-term relationship. You're likely to have a much shorter-term relationship with this patient. You likely only to see them maybe about 6 brief sessions. And so you want the two of them to be on the same page and be able to work together going forward. And one way to help them be on the same page is to literally provide them with the same page of information. And so I will often share my notes directly with the patient as well as the provider. Sometimes at the following session, I'll read the note aloud to the patient and see what they think and if this sort of makes sense to them, or send it, if there's going to be a big gap in sessions, send it to them at their home, again, with their permission to do so. So here's an example of an intake note template. This is a little bit more wordy looking, I think in part just because it's all squashed onto one slide, tends not to actually be terribly long. But you want to start off, this is, I mean, one example, but I often start off with a brief summary that just explains that this was an assessment. The goal was not to provide a comprehensive psychiatric evaluation, but rather to gain understanding of the presenting complaint and desired focus of intervention. I like that there in case the patient tries to use this later on for things like disability documentation or things like that. So it's clear that I did not do a thorough diagnostic assessment on the patient. Include who referred, you know, who's this patient's primary care provider, and did they refer this patient to, or did the patient sort of find their way to on their own? I recommend using regular, I recommend this whether you're working in primary care or not, but using sort of regular assessments in your treatment plan. In primary care, this works really, really well because it helps not only you and your patient see the change over time, but it helps their primary care provider see if this patient is changing over time in a very clear way, so that if the patient's, let's say, depression is getting worse, the doc has good evidence that maybe they need to bump up care. And if the symptoms are getting better, it helps them think, wow, this behavioral health provider is doing a great job with this patient. I should send them more of my providers. So I always include some relevant measurements that I do every time and what those scores are. And I define those scores. I don't expect that the primary care provider knows what the scores mean. Psychosocial history is only as relevant and very, very brief. What are the patient's symptoms? A review of any treatment they've had to date that's relevant. You know, is this patient taking medications? In this case, it's a patient with depression and pain. Are they on pain medication? Are they on medication for their depression? Have they tried anything else for their pain? And then just briefly what your plan is. And highlight anything that's of note specifically for the primary care provider in your plan. If your plan is that you really think this patient, for example, needs physical therapy or might benefit from physical therapy, highlight that you recommended to the patient that they talk to their doc about getting a referral for physical therapy as well. And then similarly, this is what a progress note might look like. Again, the summary. In my summary, I like to always note how many sessions in we are. Typically, I'm given about 6 sessions to see a patient in primary care, and so I want to be keeping track so I'm aware, the primary care provider is aware, and the patient's aware of where we are in that progress and that maybe we don't have that many sessions left. So this is a third of 6 sessions, what the goal of our intervention is, and then using the note to educate the patient and the provider. So here are the scores. This person is doing better. Here's their progress. here's what we focused on today. We reviewed that chronic pain wasn't dangerous. We reviewed the concept that sometimes a long-term goal is so important that it's worthwhile to take action towards it, even if it temporarily makes the pain feel worse. So I could have written, we did value-based goal setting and behavioral activation, but the patient and the provider wouldn't really know what that was. So using terminology that helps educate them about what we're actually doing. And then I like to include at the end of all of my notes, some people do this at the very beginning, I ask the providers what they like best, but a section that says of note to the primary care provider. And here, as an example, please continue to support their increasing physical activity. The patient noted that it really meant a lot to him when you congratulated him on his daily walks. So here's a really concrete thing that the primary care provider can do to help this patient and help you kind of treat them in a joint way. And also this patient mentioned that they might be interested in psychotropic meds. I recommended that they schedule an assessment with you. So in conclusion, current trends really point towards doing this patient-centered care, and that creates incentives for you more than ever to collaborate fully with primary care providers. And primary care settings and providers are really very different culturally from specialty mental health. So the more you get to know their culture, the better you're going to be able to collaborate. These docs want to hear from you. They are very frustrated when they don't. Hearing from you is going to really, really help you build your practice and provide the best care for your patients. And it can really just be very rewarding. Your patients tend to do better when you're all working together, and patients and all providers tend to enjoy this type of collaboration much more than working solo. So I really encourage you to reach out. That's it. Thank you.
Thank you so much, Dr. Weisberg. We do have a couple of questions and comments that have come in. Just scroll up to those. Sorry for the delay.
No problem.
So what type of information does a primary care provider expect from a behavioral health provider? For example, patient demographics, diagnosis, mental status, etc.
So if you're working in the site if this is a primary care patient that this provider already knows, they don't need their demographics. They know that already. And if they don't, they can look it up in their chart. So tend to almost never include any demographic information. It just takes up space, and the provider already knows that. Really want to focus on, I'll focus on mental status either. Sometimes it's in my notes because it's necessary in the system. So here in the VA, there's some regulations in certain of our systems that we have to include it. I wish we didn't. If you have to, do so. But if you don't have to, I would only include it if it's a really a key part of what you're working on with the patient, or a key part of the patient's problem. If you're noticing real mental health and mental status changes in this patient, or cognitive problems, then it's hugely important. But if everything's status quo, I don't include that. And it's really a focus on what are you working on with this patient in very, very simple terms.
Great, and I just wanted to share with you a comment that came in about how excited this particular clinician was that this topic's being presented. She's saying, as a provider working to integrate in a primary care setting, it's wonderful to see this movement going forward. And she's already shared your slides with all of her PCPs that she's working with, so they can discuss at the next meeting.
Thank you, that's great.
It looks like we don't have any other questions coming in. People can still type those in, but do you have any final thoughts that you'd like to share?
So I just want to let you know as well, in the slide deck that you all have, there are a number of additional slides that I didn't include here verbally because they're a little bit less fun to talk about. They're a little more data-filled. But they're really about how you can get more involved in this movement if you're interested. And so please do check those out if you really want to be doing more of this kind of work. There's a number of slides that refer you either to some excellent books written about how to provide behavioral health in primary care settings, journals that focus on this type of treatment, special series of journals that were really specifically focusing on this. And then there's slides on training programs if you are I know often it's folks who are already fully trained who take these webinars for CE credits, but if we've got trainees on the line, internship programs, postdoc programs that focus on this, if you are fully trained, advanced certificate programs to help people who are already fully licensed in more specialty mental health provision to get certified. Certification is not necessary by any means, but kind of help you get additional training to make you feel more competent and confident in doing this kind of work. There's a number of excellent programs that do that. And then also some great conferences that you may want to consider attending in addition to ADAA and other associations that really are sometimes outside of our off our radar, I think, a little bit as mental health providers, but that you may want to think about. So meetings that are more commonly attended by primary care providers, but that have full tracks on behavioral health, and we're sort of considering being part of to better understand the culture.
Well, thank you. And I just want to let our attendees know that they can learn more from you at the upcoming conference, April 6th through 9th in San Francisco. Dr. Weisberg will be a discussant on the session, Novel Modifications of Evidence-Based Treatments of Anxiety for Delivery in Primary Care Settings. And she's also a presenter on the symposium, Mastering the Match, All You Need to Know About the APPIC Internship Matching Program. So on behalf of ADAA and our presenter, thank you so much for joining us today, and have a great rest of your week.
Thank you so much. Thanks for having me. Bye now.